Before we begin the most awaited comedy show or the stand-up comedy for the day, we just have another very interesting, very critical congenital heart condition, tetralogy of Fallot. This condition, though rare, requires specialized knowledge for diagnosis, treatment, and management, making today's session especially valuable for both medical professionals and caregivers. We are privileged to have Dr. Durga Prasad Reddy, Head of Cardiac Sciences at Vydehi Institute of Medical Sciences and Senior Consultant in Cardio-Thoracic Surgery at Vydehi Super Speciality Hospital. Leading this session, Dr. Reddy will share his experience in cardiac surgery and his expertise in complex congenital heart conditions and make him the perfect guide to take us through the intricacies of tetralogy of Fallot. Over to you, sir.
Good evening, everyone. After a very long day, listening only to coronaries, diet, how to take care of your heart, please don't forget there is also congenital heart disease. You know, it's a very important thing. Children can become emergency while having a congenital heart disease. So why I'm talking about tetralogy, it's 1 in 1,000 of congenital heart diseases. The reason why we talk about it is, in India, every 1,000 births, we have 9 congenital heart disease. Remember that. And 2 lakh children are suffering from heart diseases in a year. And 1/5 of them are requiring an emergency surgery, which are very complex anomaly. So remember, congenital heart disease cannot be taken away. It requires very, very important guidelines to take care of children. Because to take care of a children who's got a heart disease is not that easy. Okay? Okay. So today topic is what our experience of tetralogy of Fallot at Vydehi hospitals and Speciality Hospital. So first, we need to know what is the definition of a tetralogy. Whenever I talk about tetralogy to students, young consultants, they say it's got 4 components. You know, it's got VSD, RVH, and overriding of aorta and pulmonary stenosis. They are components of tetralogy. When you say a tetralogy is a tetralogy, you have to define it well. The reason why I'm saying this, tetralogy of Fallot is a congenital heart disease where there's a RVOT obstruction and there's a large malaligned ventricular septal defect. That means the infundibulous septum is not aligned. It moves anteriorly and producing a defect at the infundibulous septum. And it also, because of the movement, what happens, this infundibulous septum goes and obstructs the right ventricular outflow tract. This is what happens. There is no actual defect. Actually, because of the malalignment of this infundibulous septum, all these things happen. And what we have to be very keenly seeing is the tetralogy VSD should be the size of the aortic annulus. When you see the VSD, the whole of annulus is seen through, the aortic annulus is seen through the VSD. Only then it can be a tetralogy. And the pressures, since the VSD is large and the whole of aorta is seen through the VSD, so the right ventricular pressure, the left ventricular pressure, and the aortic pressure should be equal. Only then you call it as tetralogy. A small VSD with a pulmonary stenosis cannot be a tetralogy. You just call it as VSD-PS. So we get all this 4 combination of lesions occur in 3 of every 10,000 live births. I'm talking only about tetralogy. Congenital heart disease, 9 in 1,000. It accounts for 7 to 10 of all congenital cardiac malformations. We do what we call as intracardiac repair for a tetralogy. We have done from 2006 to December 2023. It's a retrospective study from June 2006 to 2024. We included total correction of a tetralogy of Fallot. That means the complete repair, what we have done for a tetralogy. The exclusion criteria is the other anomalies associated with like AV canals, TGAs, and absent pulmonary valves. All these things we have avoided. We have only included a tetralogy which has been corrected completely. So we have done totally around 766 patients. Males were 556, females were 210, from the age group of 6 months to 24 years. So how does a tetralogy present? Usually These are called as blue babies. They present with mild to moderate cyanosis. At birth, usually tetralogy doesn't present with the cyanosis because there's a lot of circulating fetal hemoglobins at birth. So you don't have cyanosis at birth. So we get cyanosis after 4 months. It can be a mild to moderate cyanosis. And they also can have a respiratory distress. Usually what is tetralogy? The blood is moving from right ventricle to the left ventricle. In ASDs and VSDs, the blood is moving from the left ventricle to the right ventricle. That means, usually ASD or a VSD will get recurrent respiratory tract infection, unlike in tetralogy. The reason is, there's more blood is getting flooded into the lungs and producing recurrent respiratory tract infection. But we have also seen in tetralogies having a respiratory distress or a recurrent tract respiratory infection. The reason is, what is the action of lung? It's not only taking in oxygen and giving out carbon dioxide. It also, what is the other action of lung? It also does a phagocytic action. It engulfs the bacteria and virus and throws it away. So, in tetralogies, since there is a pulmonary stenosis, there's not much of alveolar units in the lung, these bacteria are not getting engulfed. So, you will get a respiratory tract infection even in tetralogies. So, remember, don't think a tetralogy child has come with a respiratory tract infection. Don't brand it as, mild cyanosis. Cyanosis is not visible. Don't brand it as a left-right shunt. It has to be, you have to think that tetralogies are having always less alveolar units. You can have respiratory tract infection. Clubbing. You can always see this tetralogy child, bigger childs, their fingers are little, like a drumstick or a parrot beak appearance. Why do you get that? Because there's hypoxemia into the body. That means the blood is not oxygenated. Everywhere it's only deoxygenated blood is supplied. So what happens? To overcome this, the arterioles and the venules becomes interconnected and produces little antero-posterior enlargement of the tip of the fingers. This is why the clubbing happens. And also in India, we see a lot of tetralogies having iron deficiency anemia. And polycythemia. Why there's polycythemia? Whenever there's hypoxemia, what happens? Erythropoietin is produced more. So the blood is very thick. So polycythemia. One thing you have to remember, cyanosis in you and me, when do we get you and me cyanosis? That means blue discoloration, when our saturation level drops to 85%. In anemia, only when the saturation drops to 40%, you get cyanosis. Because there's not much of unsaturated hemoglobin is not, reduced hemoglobin is not much to produce cyanosis. Same way in polycythemia, you get in 95% of saturation itself, you get cyanosis. And you also get RV failure in tetralogy. The reason why you get RV failure is because blood is pushing against the stenotic infundibulum or a stenotic pulmonary valve. So clinically, you need to diagnose a tetralogy. Everyone should be able to diagnose tetralogy clinically as a young clinicians because it's very important. Because congenital, the children cannot say anything. You have to put your step to understand why there is single S2. Because in tetralogy, what happens? The S2 is because of aortic closure and the pulmonary valve closure. Here, only the aortic valve closure is hurt. The pulmonary valve closure, the A2, P2, the P2 is not hurt because the pulmonary stenosis is there. Blood is not flowing much into this one. Closure of the pulmonary valve is delayed. So there is single S2. And there is also slightly overriding of aorta, also producing the pulmonary artery is little posterior. You can't hear the S2. And you also get an ejection systolic murmur. That means when you put a stent into the pulmonary area, there will be a sound which is occurring like this is the sound you get. Why do you get this sound? Because the blood is gushing out of the stenotic valve, producing an ejection systolic murmur. How do I play this? Can I play this? Yeah. Can you hear the sound? This is the ejection systolic murmur, This is how you get in tetralogy. Next slide. So these are the routine investigations we do. The most important is echocardiography and cardiac catheterization. And when you take an X-ray of a tetralogy, what we find is, can you see this? What shape of this? Can anyone tell? It's a boot-shaped heart. Can you see that? The heart is like a boot shape. Okay. Why do you get a boot-shaped heart? Because the blood is not going into the lungs to get oxygenated. So you get a oligemic lung fields. The pulmonary artery, which is stenosis, is usually convex. It is concave. This is the area of pulmonary artery. Usually, which is convex, will be concave. And the apex, because of the RV enlargement, the blood is pushing against the pulmonary stenosis, the right ventricle becomes enlarged and it becomes upturned. So this is how the RV is enlarged and turned upward. And there is also right atrial enlargement. Usually we don't find right atrial enlargement in pure tetralogies, unless otherwise there is a tricuspid regurgitation, which we find mostly in the septal leaflets get, adhered to the VSD and it can produce leak. And if there is also ASD, atrial septal defect, you get a right atrial enlargement. Usually we find, 95% of tetralogies have atrial septal defect, so you also include a right atrial enlargement is to be looked for. See, this is the boot-shaped heart. So, echo, when you do, I'm not showing the echo picture because you may not understand this. So, you find a pulmonary infundibular and a valvular stenosis, aortic root overriding, which is 50 to 80%, a ventricular septal defect, which is malaligned and large, where a complete aortic annulus is seen through the VSD, and also right ventricular hypertrophy because of the pressure which is faced by the right ventricle against the pulmonary stenosis. Most important finding for operating, the surgeon like me, we need to know what is Magoon's ratio. There's some calculation we do so that to see the outcome of intracardiac repair after we operate on a tetralogy of Fallot. So what is this Magoon's ratio? So this is the sum of LPA and RPA diameter at the bifurcation. Can you see the yellow marks? At the bifurcation of the LPA and RPA, you add on and then divide it with the descending thoracic aorta at the level of diaphragm. So the normal value should be 2 to 2.5. Anything above 1.6 or 1.8, you have some good results when you do an intracardiac repair. You have something less than 1.5, it's a borderline. Less than 1, we don't do intracardiac repair. We do something called as palliative surgeries. I'll come to that. Can you play this, please? There's something called as cardiac catheterization. We inject into the right ventricular outflow. Since there is a large VSD, what happens is, usually when you inject into a right ventricular outflow dye, what happens, only the pulmonary artery is delineated. But in tetralogy, since there is a large VSD, the aorta and the pulmonary arteries are getting delineated. Can I play this video? Yeah, can you see this? Injection of dye into the right ventricle, the aorta, the pulmonary artery, through the VSD. This is the VSD. This is the VSD. Can you play it again? See, the dye is getting injected into the right ventricular outflow tract. See, through the VSD, it is delineated into the aorta and to the pulmonary artery. Can I have my pointer, please? This is very light. Canon is it? I gave my pointer to him. I just can give a pointer. This is very light. Sorry. It's working, but it was. Thank you. Okay, no problem. So whenever a child comes with a tetralogy, you always give a child on oral propranolol, which is a beta blocker. Why do we give beta blockers in tetralogy? Is because we reduce the heart rate. By keeping the heart rate low, you reduce the systemic, you increase the systemic vascular resistance, so that sudden getting into cyanotic spells or sudden deepening or becoming unconsciousness can be avoided. So always when you see a tetralogy child, they always have this drug called Indral. Indral is nothing but oral propranolol, which has been given worldwide. And after admission, what we do is after admission, what we do is we have to check for hematocrit. If the hematocrit is more than 65, what we do is we have to remove this blood. How do we remove blood? We do a phlebotomy. We remove at least around 500 ml of blood, or sometimes even 2 pints of blood are removed. And this is replaced with fresh frozen plasma. We do it in consecutive stages, not one day we take 2 days, 3 days. By doing that, we always get this hematocrit to less than 45. Because that is safer when we operate, the blood should be in an apt level. Because if hematocrit is very high, the blood is very thick. It produces more serious issues like brain clots or clots into some other areas. And then if there's any anemia, you also have to correct this anemia and take up for surgery. Before we go into intracardiac repair, we need to know what is cyanosis. What is cyanosis? Cyanosis is nothing but a bluish discoloration of skin and mucous membrane, where there's a reduced hemoglobin it should be more than 5 grams per deciliter. If the reduced hemoglobin is less than 5 grams, you will not get cyanosis because you need to have a reduced hemoglobin which is more than 5 grams per deciliter. And every emergency should also look into cyanotic spells. It's not coronary artery disease. Even children can have emergencies. They can be rushed to the ER. And you need to know when you have to treat and how. You have to identify this is cyanotic spells, and you need to know how to treat the cyanotic spells. What is the definition of cyanotic spells? It is sudden, prolonged crying, hyperapnea, child will start breathing heavily, irritability, and when you put your stent into the pulmonary area, there is no murmur because there is no blood going into the pulmonary artery because this is what happens in tetralogy. I'll come back to the mechanism why the cyanotic spells happen. And there's also deepening of cyanosis. Since there's no blood, there was little blood going into the pulmonary artery, but in cyanotic spells, there is no blood going into the pulmonary artery, and the cyanosis become deepening, and the patient will start becoming limpness. That means patient is silent, cold, unconscious, not responding, convulsions, cerebrovascular accident, and death. This is what we see in cyanotic spells. So how do you break the cyanotic spells? You need to know why there is first of all, you need to know the mechanism of cyanotic spells. There's a lot of theories which has come for cyanotic spells. This is a proven theory, and we also found by doing these things intraoperatively to find out why the cyanotic spells have been cured. Intraoperatively, we have demonstrated these things. I'll come back to you how we have demonstrated treating cyanotic spells. So what happens when the child starts crying? There will be tachycardia. You and me, when we get, everyone I'm sure we would have got into a vasovagal attack. What happens in a vasovagal attack? You feel dizzy, you feel like lying down, you feel unconscious. So what happens that time? The whole blood is getting pulled into the lower limbs. Same thing happens. That means what? The systemic vascular resistance drops down. Why does the systemic vascular resistance drops down? Because the child is tachycardia, irritable, and long crying. So systemic vascular drops. A lot of people say when the child is irritable, tachycardia, there is adrenaline is rushed and there is spasm of the RVOT. It is not true. The pulmonary vascular resistance is a fixed point. There is no spasm of RVOT. So what happens here is there is a drop in the systemic vascular resistance, and there's more increased right-left shunt. And all the blood is sucked into the aorta. No blood is going into the pulmonary artery. When it continuously happens, what happens? The child becomes acidotic. That means there is decreased PO2s, increased PCO2, and decreased pH. And once the child is acidotic, child will start breathing heavily, hyperapnea. Hyperapnea means the negative thoracic pressure is high, and a lot of blood is coming into the right heart, and more blood is, that means what you call a systemic venous return. That means more blood is coming into the right atrium, more blood is coming into the right ventricle, and all the blood through the VST going into the aorta, not going into the pulmonary artery. This is what happens because there's a decreased systemic vascular resistance. So how do you break this? You break this, usually cyanotic spells are treated in ICU care. You administer oxygen, and you always put the child in knee chest position. That means you go back of the child and hold the child with the knee and put the knee to the chest of the child. By doing this, what happens? There's compression of femoral artery. By compressing the femoral artery, you increase the systemic vascular resistance, and also it also compresses the femoral vein. By doing that, you also decrease the systemic venous return, because all the blood which is returning into the heart also is blocked by compressing the femoral vein. And at that point, you check for the appearance of ejection systolic murmur. That means if the murmur appears, that means the child is becoming all right. The blood has started going into the pulmonary artery, and the cyanosis also becomes lessened. That doesn't become all right. You give some drugs called injection phenylephrine, alpha-adrenergic blockers, beta blockers. Why do you give that? To reduce the heart rate and increase the systemic vascular resistance. You also give morphine. Morphine is a good drug because it abolishes the respiratory center, and the respiratory breathing pattern is reduced, hyperapnea is reduced. Give ketamine to increase the systemic vascular resistance, correct the acidosis with the bicarb. In severe cases, still intractable cyanotic spells, not able to treat with drugs, not able to treat with mechanical issues. What you do is you ventilate the child by intubating, and also plan for an emergency BT shunt or an intracardiac repair straight away. So this is how we put in knee chest position. You always make sure you keep it for 1 minute. Don't keep putting in knee chest position, then removing and check for the murmur. Keep it for 1 minute sharp, and then check for the appearance of murmur, and also simultaneously give phenylephrine and propranolol. What happens when the Magoon's ratio I was talking, what happens when the Magoon's ratio is less than 1, the PA size is, the main PA is 0.5 millimeters, you do a modified BT shunt. What is that modified BT shunt? We connect a conduit between the branches of aorta into one of the pulmonary arteries, whether it can be right or left pulmonary artery. This is what we do. Through a thoracotomy we do. If the Magoon's ratio is less than 1, PA size is less than 0.4 millimeter, then we don't use lateral thoracotomy. We open the chest, do a central shunt between the main PA and the aorta through sternotomy. Then the Magoon's ratio is more than 1.5, PA size is 1 centimeter, you do an intracardiac repair through sternotomy. Unless there is a coronary which is crossing over RVOT, you do a central shunt, wait for 5 years, let the coronary become big, then do an intracardiac repair and do an internal mammary artery graft to the LAD. This is the central shunt which is being directly put. Usually, initial days what we were doing is we are connecting aorta and PA a small shunt, which we don't do it now. The reason why is because once the pulmonary artery becomes a little bigger, all this blood from the aorta gushes straight into the pulmonary artery, producing pulmonary edema and all these things. So what we designed is we put a tube into the aorta, make a central channel like a curve, like a concavity we give. And that once we put that, what happens is this conduit becomes straight away becomes a right angle to the aorta. To make it parallel, what we do is we tie a loop into this one and then tie it onto the RA so that it becomes a little parallel to the heart. In operating theater, we need to sometimes, lot of times what we see is when we open the chest, the child get into cyanotic spells. So we should quickly plan for a cardiopulmonary bypass. I will show you how we do this. And we give IV phenylephrine, bicarb, ketamine. And there's one more technique. This is the technique I was talking. We clamp the ascending aorta. For 5 seconds, we just put a clamp. We put a cross clamp across without going on pump. We cross clamp the aorta and also cross clamp the inferior vena cava. By cross clamping the aorta, what happens? You're increasing the systemic vascular resistance and forcefully pushing the blood into the pulmonary artery. And by clamping the IVC, what we are doing, we are also decreasing the systemic venous return. Once this is done, the child is slightly all right, we proceed to cardiopulmonary bypass. What is cardiopulmonary bypass? We put a cannula into the superior vena cava, put a cannula into the inferior vena cava, drain all the blood into a reservoir here, and shift this blood into a container where it gets oxygenated. This oxygenator contains semi-permeable membrane, which is polytetrafluorethane. So many materials are there. So when this happens, this is like similar diffusion mechanism where our alveoli and the capillaries happen. Same mechanism is incorporated into the oxygenator. That is filtered and then pushes back the blood into the aorta. Still the heart will be beating. By doing this, the heart is empty. We are just draining all the blood and giving, we are bypassing. That is cardiopulmonary. The heart and lung has been bypassed. We are taking all the blood and giving a pure blood, oxygenated blood. The function of the heart and lung is exterior. This is what we do. But still the heart will be beating. So what we do is, we put a clamp here. We put a clamp here. And we also cannulate another cannula and give something called as cardioplegia, which contains high potassium. That enters the coronary arteries. This is the coronary arteries. That enters the coronary arteries, and then the heart stops in diastole. This is what we do. So surgical technique for intracardiac repair, we establish CVP, that is cardiopulmonary median sternotomy. We open the chest. We do we establish cardiopulmonary bypass, arrest the heart by giving antegrade cold cardioplegia with potassium. And there are a lot of steps we do. We do VSD and infundibular stenosis should be approached through a right atriotomy through a tricuspid valve. And the pulmonary valvotomy is approached through the pulmonary valvotomy. So what is total correction? This infundibular resection is done. This is where the infundibulum septum is moved anteriorly, is resected so that it doesn't block the pulmonary RVOT, right ventricular outflow tract. And we also close the VSD with PTFE patch. And do a pulmonary valvotomy. And we extend the valvotomy across the right ventricle outflow tract and reconstruct with a transannular autologous pericardial patch used by the patient's pericardium itself. So this is a video for intracardiac repair. This is the infundibular septum, which is, can you see that? See, this is the infundibular septum, which is blocking the pulmonary artery. We excise it. Make sure we don't core out completely because the coronaries are running on the myocardium. So we need to make sure the myocardium doesn't get dipped when we are cutting that infundibular septum. Can you see this infundibular septum? This is the infundibular septum. You have to resect it. And see, can you see the VSD and the aortic annulus there? We use a PTFE patch. We design a patch slightly oval. This is a 0.6 or a 0.4 millimeter PTFE patch. Because we don't use pericardium there, because pericardium is thin, you can have a pseudoanus. Can you see the aortic annulus? Can you see the aortic annulus there? The first stitch should be at the inferior border of the VSD. Always with a pledgeted stitch. Take it to the patch again. Make sure the stitch doesn't enter the VSD because the conduction is running here. You have to be superficial, not very deep there. We use 6-0-prolin. Once the patch is, we always push the patch inside the VSD. Take a continuous stitch. This is the aortic area. Be careful not to go deep so that you will injure the aortic valve or you produce the aortic regurgitation. You take continuous stitch. When we come to the septal, this is a septal leaflet of the tricuspid valve. A lot of techniques are, we do interpreted stitches there to avoid conduction, but our team doesn't do that. What we do is we straight away take continuous, make sure the stitches are very far, and I'll show you how the stitches come out. We take it far and deep there where there is no conduction and come into the right atrium. This is what we bring the stitch into the right atrium. This is only a continuous stitch. We make sure the VSD is continuously stitched onto the patch, PTFE patch. Why we use PTFE patch is because its tensile strength is very good. Because the right ventricle, left ventricle, the pressure is very high. You can produce pseudoaneurysms and other things. So we make sure we use a PTFE patch. Initial days when the patients were not affordable and things, we are using autologous pericardial patch. Now we gave up because we found few patients having aneurysmal dilatation of the pericardium, occluding the pulmonary artery outflow. And make sure at the lower end, don't go very deep, so that you don't hit the conduction there. Once we hit the conduction, I think our technique, we've been very authentic in saying that we use continuous far and superficial stitches at certain areas so that the conduction system can be avoided. And out of this 800 or 766 patients, we not even had one conduction problems in our cases. And once we do that, we open the pulmonary artery. This is the pulmonary arteriotomy, cut across the valve, and we also cut across the right ventricular outflow tract. And this is the, see, can you see this pulmonary, this is the right flow outflow tract. Excess of infundibular muscle is excised even through the pulmonary arteriotomy. This is the pulmonary valve. The technique, what we follow is, we don't excise the complete pulmonary valve. Only the anterior aspect and the lateral aspect of the pulmonary valve is excised, so that it doesn't produce too much of pulmonary regurgitation. So that it will have a little bit of protection so that all the blood is not producing pulmonary regurgitation. We size the right ventricular outflow tract with Hagas. Suppose the Haga size is 10. We use, 16 Hagas, we allow it to pass it. At least, 6 millimeter size is more. We close the right ventricular outflow tract with the autologous pericardium patch. This is what we do. All are used with 6-0 proline stitch, because we don't use bigger stitches because this pulmonary artery is very thin there. Most of these pulmonary artery stitchings are with autologous pericardium with the 6-0 proline. This we run through continuously. Can you slightly fast forward this? Possible? And whenever we take this pericardium, be careful. These pericardiums are soaked in glutaraldehyde. Make sure these patches are washed very well. The reason why I'm saying this glutaraldehyde is highly irritant. It can produce myocarditis. I've seen people having even hepatitis because this all this pericardial patches will have a small tissue which all this glutaraldehyde gets entrapped into these tissues and can produce hepatitis. So make sure you wash the pericardium thoroughly, almost 3 to 4 washes, soak it in normal saline before you use it. This is a continuous stitching of autologous pericardial patch. Once it is done, we tie the knot. So usually we discharge in 7th day. We had some deaths, the reason for RV failure. And we also say in tetralogy child, whenever the child is complaining of headache and things, make sure you see MRI because they can have a thrombus there or a brain abscess. So we follow these children's 3 months, 1 year and 5 years by ECG, X-ray and echocardiography. And what we found is severe residual VSDs in 2 patients. 2 patients, adult patients, which we did tetralogy, patch closure, gave way because in adults what happens, the infundibular septum is very friable. Whenever the heart rate increases in the ICU, they can give up. So we took up immediately and we closed with interpret stitches and mild to moderate PR in 27 patients. They're clinically all right and we're closely monitoring them. So this technique has improved our intracardiac repair in a very vast thing. We never had any issues and still we are following how the right ventricular function and the pulmonary valve is modulating to this intracardiac repair. So this is our team which works, teamwork works, that's what I believe. Thank you. Any questions from audience? I can take it. Yeah. See, I forgot to say this. See, always in congenital heart disease, whenever it starts from marriage. You know, you need to understand. You need to not have consanguineous marriage. That means don't get married to your own first cousin, or sometimes even in, they marry their own sisters and brothers. Please avoid that. Consanguinate marriage produces a lot of congenital heart disease. Second thing is antenatally, don't smoke, especially women's, they start smoking. Nowadays you see most of the women smoke in Bangalore, and that smoking continues during marriage. They make sure they get married to a person who smokes with them. And they, after marriage also, they start smoking. When they become pregnant, they smoke. Smoking produces intrauterine growth retardation of the child. That can also produce tetralogy. Alcohol. Alcohol also is very dangerous because there's something called as fetal alcohol syndrome. So all these things should be diagnosed pre-op. So you have to advise a pregnant woman, no alcohol, no smoking. Alcohol sometimes they can avoid, but smoking, once they get used to smoking, they'll start smoking in pregnancy, thinking that it is not going to the uterus, it is only going to the lungs. But hypoxemia, 3 cigarettes is enough to clog your arteries, it will produce hypoxemia. And I think intrauterine growth retardation is mandatory when you start smoking heavily. So don't drink, don't smoke, and try to avoid viral infections during pregnancy. This is a very important thing, because once a viral infection starts coming into pregnancy, what happens is children will get maternal rubella infection. You get a lot of congenital heart disease in this. So these are things. And always I suggest any pregnant women, 5th month anomaly scan is mandatory. So tetralogies can be well managed, but there are a lot of complex anomalies. Even you operate, their quality of life is not good. So they can plan their pregnancies. Always 5th anomaly scan in the best center should be made possible. So this is what it is. And always make sure the diabetic mothers who are pregnant, gestational diabetes, make sure you control the sugars by diet and drugs or whatever it is, so that the child doesn't get affected, when they have diabetes. And you also see whether mother has got any congenital heart disease. 15% gets transmitted to children. So you have to be careful in these things. The most important things is consanguineous marriage, smoking, alcohol, drugs, aspirin. People, when they have pain, they take painkillers. We have to be very careful when you take painkillers. You get pulmonary hypertension when you take painkillers. So these are the things you should avoid during pregnancies and other things. Anything else? Yeah. Tetralogy? That's what I said. It all depends on the Magoon's ratio. If the Magoon's ratio is more than 1.5, I straight away go and do intracardiac repair. I think success rate is, we have done close to 800. I think we have lost around 27 children. They're very complex. That means the surgery per se is not an issue. What happens, they're cyanotics. They become blue. The blood is thick. They produce a lot of liver dysfunction, kidney issues. They have brain abscess. There are a lot of other issues which crops in. So that's why, the right time you need to operate. You need to operate when you see a tetralogy, start preparing for operation. You don't take them more than 1 year to operate. If their Magoon's ratio is more than 1.5, straight away go and operate this tetralogies. You wait, the poor background is there, they don't have money. The government is sponsoring, a lot of Aragshris have come, Ayushman Bharat, they've been operating. Now a lot of Sanjeevani hospitals have come, we're doing free, we are also doing around 30 to 50 free pediatric cardiac surgeries every year. So they have to make use. The awareness is they have to come, get the screening echoes done, make sure they're being operable at the right age. They'll be successful 100%. You should not allow the complications to happen. Once you allow the complications to happen, like cyanosis complication, the RV failure complication, then the success of the surgery is not okay. So you need to be very careful. Surgery per se is very good when the right decision is taken at the right time. That's it. Any other questions? Close? Yep. I can't hear you, ma'am. See, whenever you diagnose a tetralogy, I think you need to show to a cardiologist, make sure the Magoon's ratio is good, child is operable, you plan for surgery. That's the only way. There's nothing medical treatment. All this medical management, what I was saying, is to prevent cyanotic spells. Otherwise, when you find a tetralogy, you have to operate. There's no other things. There's nothing called as you put a device closures, and you have to do an intracardiac repair. That's the only way you can save the child. I understand. If the cyanotic spell starts and you're not able to diagnose pre-op, you don't have a diagnosis. You didn't have a diagnosis pre-op this tetralogy. Yeah. If you have a cyanotic spells, let it be tetralogy, let it be TGA, anything. Cyanotic spells happen only in tetralogy per se. Other cyanotic cardiac diseases, other than tetralogies, you don't find cyanotic because the mechanism is different there. You become cyanotic, but you will not get cyanotic spells because cyanotic spells you need to have a large VST first. And the pulmonary stenosis should be there. In pulmonary atresia, you won't get cyanotic spells. Child is always born dark, two deepening cyanosis. So you need to only produce a cardiac output by creating an ASD or a VSD. So that is how it is. So cyanotic spells only, most of the time you get only in tetralogies. And if you have not diagnosed this, still follow the same mechanism what I said. See for the appearance of murmur. Still the murmur is not appear. Get an echocardiography quickly, move him to the theatre and do a shunt. So that little bit of oxygenation is happening into the pulmonary artery. Okay?
Thank you, Dr. Durga Prasad Reddy, for such an informative session. A huge round of applause for Dr. Reddy. I now request Mr. Raghu Krishnan, Chief Editor, Print and Publishing, to felicitate Dr. Durga Prasad Reddy. Thank you, Mr. Raghu Krishnan. Thank you, Dr. Durga Prasad Reddy.